Hello everyone. Here we are presenting an interesting case on guest dancer in the retina. A 41-year-old male patient who is a coolie by occupation presented to the OPD with sudden loss of vision in the right eye since the past 4 days. On evaluation, right eye vision was hand movement. IOP was 12 millimeters of mercury. There were occasional cells in the anterior segment and posterior segment had few RL cells. Left eye had esotropia. Rest examination was unremarkable for the left eye. This is a fundus photo of the right eye of the patient. It shows disc edema. Presence of multiple yellowish white lesions. Motile worm can be seen in the macula, motility of which will be demonstrated along with macular edema. This image shows motility of the worm, which can be demonstrated using AIOS2025-VT124-Dr.Sharat lens. The same motility of the worm can also be demonstrated in the OCT image on the right hand side. This is an OCT angio image. Here we were able to capture the worm since the OCT angio has 8 slabs and it works on the principle of particle motion. So the worm can be demonstrated in the OCT angio. Thereby we conclude the diagnosis as diffuse unilateral subacute neuroretinitis in the right eye of the patient. Focal laser was attempted as first line of management for treating this worm. We tried to hit the worm with focal laser in the extrafoveal area. We even showed light and waited for 6 long hours, but we were unsuccessful as the worm was very mobile and direct hit over the worm was not possible. Let's talk in brief about DUSN, starting with introduction. Diffuse unilateral subacute neuroretinitis is an ocular infectious disease which is caused by nematodes which are capable of infiltrating the subretinal space. Parson first identified this ocular syndrome, which was associated to a subretinal mobile live worm and accompanied by diffuse chorioretinitis in 1952. Gass and Scelfo later named this as wipeout syndrome, and later in 1978 it derived its name DUSN, which was given by Gass and colleagues. It can be caused by 4 types of worm: the nematodes, the roundworms, trematodes, and even hookworms. Clinical features can be classified into acute stages and the late chronic stages. The early acute stages involve central or paracentral scotoma, visual acuity loss, vitritis, presence of disc edema, recurrent crops of multifocal outer retinal white lesions. Late stages show features of profoundly decreased visual acuity, diffuse and focal depigmentation of the RPE, optic atrophy, retinal arteriole narrowing, and crisscross pattern of the subretinal tracts. This is an image showing both acute and chronic phases. In the first image, you can see multifocal retinal lesions, which are yellowish in color in the acute stage. There is also presence of the orifice sign. This is nothing but enhancement of the ILM. Coming to the image just beneath it, another acute finding. This shows presence of disc edema. Brown mobile worm can be seen along with macular edema. Coming on to the chronic features, coming on to the right upside image, which shows presence of optic atrophy, foveal thinning, and the last and fourth image, it shows Garcia's sign, which is presence of subretinal tracts. You can see the whitish yellow tracts present. This image shows macular edema along with neurosensory detachment, disc edema, and the mobile worm can be seen, which is usually in the acute stage. Coming on to the chronic stage on the OCT, mean RNFL thickness is reduced, central macular thickness is also reduced. There is loss or blunting of the foveal contour. However, the ISOS junction remains intact. Coming on to the treatment, oral drugs, antihelminths are the mainstay of treatment, which include thiabendazole or albendazole, along with steroid cover. The steroids give initial improvement, but long-term benefits are not really seen with them. In our case, we did our investigations, the blood baseline investigations. They showed mild raise in ESR and the stool tests were normal. Extrafoveal laser was done initially, which was minimal, but we were not able to hit the worm. Then Tab albendazole 400 mg with ivermectin was given stat, followed by albendazole 400 mg at night for 2 weeks. This was given under steroid cover with tapering doses. Next day follow-up showed the worm half paralyzed, as you can see in the image, and there was slight increase in the macular edema. In the OCT image also, you can see the worm moving, but only half moving, half of it is dead, so it is immobile. This is the 1 week follow-up image on the left-hand side where you can see the macular edema is resolved. Disc edema is also better. The patient's symptoms had also improved. His visual acuity was 6/36 by now. In the right side, you can see the OCT image where the neurosensitive detachment has resolved and there is no evidence of any macular edema. Take-home message. This case shows importance of multimodal imaging in case of DUSN. Laser photocoagulation to the visible worm is ideal. In case of non-visualization and absence of vitritis, laser photocoagulation may result in destruction of the worm. It may facilitate intraocular duct penetration by disruption of the blood-retinal barrier. Single dose of concomitant oral ivermectin and a 2 weeks of oral albendazole is effective. Also, awareness to be given regarding hygiene maintenance. Me? No, I'm just a worm. But I can be a troubleshooter anywhere. Thank you.